Hi everyone, Andrea and Ernie here from the First Aid at Work podcast.
We are so excited to introduce our new podcast specifically designed for students.
Hello everyone and welcome to this critical audio breakdown of your First Aid at Work handbook. I'm Andrea and I'm joined by my longtime colleague.
Hello there, I'm Ernie.
We've worked together for years as UK paramedics and, well, we are absolutely thrilled to be supporting your training this week.
We are, yeah. Now, we know you're currently attending the 2-day practical course with, well, the legend that is Paul Kenny from the First Aid Garage.
He really is.
You are in incredibly safe hands. I mean, Paul's experience stretches back over 4 decades on the front lines, both within the NHS and the private sectors.
Mm-hmm.
There isn't much that man hasn't seen, and the wisdom he brings to your training is, well, it's invaluable, really.
Absolutely. So our mission in this deep dive is, I suppose, to bridge the gap between that thick FAW manual you've got in front of you and the high-pressure, real-world situations you might face.
Especially within a school environment.
Exactly. We're going to look at the protocols, the signs, and the treatments, but tailored for everyone you look after, from your year 7 student, so around 11 years old, right up to your adult colleagues in the staff room.
And we've broken this down systematically, sort of following the structure of the manual, starting with the immediate life-saving priorities.
The big stuff first.
The big stuff first, yeah. So grab a drink, keep your handbook nearby for reference, and let's jump straight into the fundamentals.
The primary survey and basic life support.
Spot on.
Okay, so let's unpack this crucial groundwork. Before we, lay a hand on a casualty, we need to quickly review the 3 main aims of first aid. We often teach this as the 3 Ps, don't we?
We do, yeah. It's a good mnemonic.
The first and most important is to preserve life. I mean, this is the absolute core of it. It means ensuring the casualty's breathing and circulating blood.
And the second P is to prevent the condition from worsening. Now, this covers everything from preventing infection by using gloves, which is huge.
Oh, massive.
To managing a fracture, so it doesn't cause further soft tissue damage down the line.
And the third P?
That's to promote recovery. So making the casualty as comfortable as possible, keeping them warm, reassuring them until professional help arrives.
And those aims, they sort of inform your primary responsibilities as a designated first aider, don't they? One of the most critical aspects, especially in a public setting like a school, is minimizing that infection risk.
Hugely. You have to treat every single incident as if there's a risk of cross-contamination.
Assume the worst, in a way.
You do. That means impeccable personal hygiene, ensuring any cuts you might have are covered, and crucially, using personal protective equipment, your PPE, every single time.
And what are we talking about specifically?
We're talking about nitrile gloves as a minimum, and if you are giving rescue breaths, a suitable barrier device like a resuscitation face shield or a pocket mask. You need to create a barrier between you and any bodily fluids. Simple as that.
So once you've secured yourself, your responsibility is then that rapid assessment. You need to determine what happened, what the life threats are, and summon appropriate assistance using clear communication.
Yeah, and we promised we'd revisit the LINE acronym, which is just so essential for summoning help quickly and effectively, whether you're speaking to a bystander, a colleague, or 999.
So let's break that down. LINE.
Okay, so L is for location. Where exactly are you? School name, classroom number, the football pitch by the oak tree. Be specific.
I is for incident. What has happened? A student has collapsed, or a colleague has severe bleeding from their arm. Short, sharp, to the point.
N is for number. How many casualties are there? What's their age, their gender, if it's relevant? And finally, E is for emergency services required.
So you'd say something like, we need an ambulance immediately.
Exactly. That clear communication just saves so much time. If you tell a colleague, call 999 and use LINE, they know exactly what to say to the dispatcher. There's no panic, no confusion.
With those responsibilities understood, the first step when you're actually approaching a scene is that systematic scene survey. We use CLAP to remind us how to arrive safely and take charge.
CLAP is your internal checkpoint, isn't it? It's what you run through in your head before you start any hands-on treatment.
So C.
C is for control the situation. You have to pause, take a breath, and remain calm. In a chaotic school hallway, students and staff will look to the first aider for authority. You must take charge, delegate tasks, and maintain that calm presence.
Which is easier said than done sometimes.
Oh, absolutely. But it's vital. Next, L is for bystanders. This is about the safety hierarchy, and it's non-negotiable.
Your safety first.
Always. Your safety first, then bystanders, so students or other staff, and finally the casualty. If there's a spill, a fire, any ongoing danger, even a loose piece of equipment in the gym, you have to make that area safe or remove the casualty before you go any further.
Because you can't help if you become a casualty yourself.
Spot on. Next, A is for Ageriant. Assess the situation. Gather information quickly. What are the visible injuries? What's the history? If the casualty is conscious, ask them what happened.
And if they're not?
Then you talk to bystanders. Look for signs. That's what you can see. And symptoms, which is what the casualty tells you.
And finally, P.
P, protect and prioritize. Protect yourself by getting your gloves on, and then prioritize treatment based on the immediate life threat.
And that hierarchy is universal.
It is. It's breathing, bleeding, bones or burns, and then any other, non-immediate conditions.
And here's a crucial nugget of information, especially if you're dealing with a multi-casualty incident.
The quiet one.
The quietest casualty. That's often the one who needs attention first because they may be unresponsive or not breathing. A person screaming is, at the very least, moving air.
A very, very good point. So once the scene is safe and you are at the casualty side, you then move into the primary survey. You're focusing on life-threatening conditions using that ultimate checklist, DRBCD.
Let's break down DRA-BCD properly. D is always danger. Repeat it again just to hammer home that your safety is non-negotiable.
Then R is for response. And we use the AVPU scale to gauge their level of consciousness.
So AVPU. A is
alert. They're talking, moving, fully aware. V is for voice. They only respond when you speak to them. P is for pain.
And this isn't about hurting them, is it?
No, not at all. It's a physical stimulus. A gentle shake on the shoulders while you're asking loudly, "Are you all right?"
And U is unresponsive. Now, if they respond, so they're an A or a V, you leave them in the position you found them in. If it's safe, get the history, try to find out what's wrong, and reassess their condition constantly.
But if they are unresponsive, so a P or a U, the whole situation changes, and you move immediately to open the airway.
So A is airway. The goal here is simple. Move the tongue. It's the most common cause of airway obstruction in an unresponsive casualty.
It just flocks back.
Exactly. So you gently place them onto their back, and you have to be careful here. Minimize movement of the neck and spine, and open the airway using the head tilt chin lift method.
So that's one hand on the forehead, gently tilt the head back, and then you lift the jaw point with your fingertips under their chin. It's a simple maneuver, but it often solves the problem immediately.
Then comes B for breathing. Once that airway is open, you must look, listen, and feel for normal breathing. And for no more than 10 seconds.
That time limit is strict, isn't it?
It is. You are looking for chest movement, listening for breath sounds at their mouth, and feeling for air movement on your cheek. 10 seconds. Any longer is just delaying potentially life-saving CPR.
And this is where we have to deliver the agonal gasps warning.
This is so important.
It's critical. Agonal gasps are a very common feature in the first few minutes after a cardiac arrest. They're often described as infrequent, slow, noisy, or snort-like breaths. They are not normal breathing.
But they can fool you.
They can. So if you are in any doubt whatsoever about the quality of the breathing, if it's not smooth, regular, and deep, you must assume the casualty is not breathing normally.
And you act.
You act immediately. You prepare for CPR. Delaying CPR by mistaking these gasps for normal breath just dramatically lowers the chance of survival.
So, if they're breathing normally but they remain unresponsive, you put them in the recovery position, call 999, and monitor them constantly.
But if they are not breathing normally, we move straight to C circulation and the CPR protocol, which, and this is important, adheres strictly to the UK Resuscitation Council guidelines.
Right. So, unresponsive and not breathing normally, CPR starts immediately. The ratio for an adult or a child post-infancy is 30 compressions to 2 rescue breaths, 30.2.
Let's focus on the technique for a second, because how you do it is paramount to its effectiveness.
The casualty has to be on a firm, flat surface.
Yeah.
If they're on a soft school sofa or, boggy ground outside, you need to safely move them to the floor.
Then you place the heel of one hand in the dead center of the chest, right on the breastbone. Your other hand goes on top, interlock your fingers.
Then your arms.
You must lock your elbows straight. Position yourself vertically above the chest. You're using the weight of your body, not just your arms. You'll tire out in seconds otherwise.
And the compression depth is critical, isn't it? 5 to 6 centimeters.
It is. That's about the height of a standard credit card stood on its edge. It feels very deep, but it's absolutely necessary to effectively pump that blood.
And the rate? The speed?
We need to maintain a rhythm of 100 to 120 compressions per minute. This is incredibly fast.
It's relentless.
It is. Most people find it helpful to hum a tune. Think of staying alive, or, as I know Paul often suggests, Nelly the elephant. That speed ensures we're circulating oxygenated blood to the brain and the vital organs.
So after 30 of those compressions, you deliver 2 effective rescue breaths, and that whole process should take no more than 10 seconds.
And an effective breath is key. It means you see the casualty's chest clearly rise when you breathe into them. If you're trained, able, and it's safe to do so, always give those breaths. They supply crucial oxygen.
However, we do have to acknowledge that in certain scenarios, maybe due to scene contamination, personal safety concerns, or simply being untrained in rescue breathing compression, only CPR is acceptable.
Absolutely. If you cannot or will not give breaths, you just maintain continuous, fast compressions at that 100 to 120 rate. Do not pause. Any compression is always better than no compression.
So you continue this 30.2 cycle until when? When do you stop?
Until one of 3 things happens. A health professional, like us or Paul, takes over. You become physically exhausted and simply cannot continue. Or the casualty shows definite signs of recovery.
And what does that look like?
Moving, opening their eyes, or, crucially, beginning to breathe normally on their own.
And that CPR sequence is the second link in the chain of survival. Time is just the absolute enemy of survival in a cardiac arrest.
The chain of survival has 4 critical links. First, early recognition and calling for help. That's getting 999 on the way.
Second, early CPR to manually circulate blood and buy time.
Third is early defibrillation to try and reset the heart's rhythm. And finally, post-resuscitation care, which is provided by the ambulance crew and the hospital staff.
And the statistic you really need to remember is, well, it's pretty sobering. For every minute that passes without effective CPR and defibrillation, a casualty's chance of survival diminishes by 6 to 10%.
Which is huge. So if an AED is available, it needs to be integrated into your CPR sequence immediately. No delay.
An AED, an automated external defibrillator. They're designed to be really user-friendly, aren't they?
They are. The first step is always to switch it on and just follow the voice and visual prompts. If you have a colleague with you, one person continues CPR while the other prepares the AED.
Preparation means exposing the casualty's chest and attaching the electrode pads exactly as the pictures on the pads direct, ensuring they are placed firmly and securely.
And a quick reminder here, avoid placing pads directly over any metal piercings or a visible pacemaker device under the skin. If there are medication patches, you need to rip them off and wipe the skin dry before applying the pads.
Right. Once the pads are on, the machine takes over, starts analyzing the heart rhythm.
And at this point, you must loudly and clearly call, "Stand clear," and ensure absolutely no one is touching the casualty during the analysis or during the subsequent shock delivery.
And the defibrillation algorithm itself is simple.
Very. If the machine advises a shock, you ensure everyone stands clear, you press the shock button or let the machine deliver it automatically, and then immediately resume CPR. 30.2 for 2 minutes.
And if no shock is advised?
You immediately resume CPR, 30.2 for 2 minutes. You just keep following the prompts until help arrives.
Right. So finally, post-resuscitation care. If they start breathing normally, or if they were unresponsive but breathing normally from the start, we move them into the recovery position.
This position is used when the casualty is unresponsive but breathing normally, is relatively uninjured, so no obvious spinal trauma, and doesn't need CPR.
And its purpose is strictly to maintain a stable, open, and draining airway.
Exactly. It ensures that vomit, blood, or saliva can't obstruct the back of the throat.
Let's walk through the procedure, as this is a core practical skill you'll be perfecting with Paul.
Okay, so you kneel beside the casualty. First, remove any bulky items from their pockets. Then, place the arm that's nearest to you at a right angle to their body, bent at the elbow, with the palm facing upwards.
Next, you bring their other arm across their chest, and you secure the back of that hand against the cheek that's nearest to you. You've got to hold it there firmly.
With your free hand, you grasp the clothing around the knee that's furthest from you and draw that leg up, keeping the foot flat on the floor.
Now, keeping that hand pressed against their cheek to control the head and neck, you pull their knee towards you, rolling the casualty gently onto their side.
Once they're safely on their side, you just adjust the upper leg so that the hip and the knee are at right angles.
Yeah.
This creates a really stable sort of tripod base.
And you check the airway one last time, tilting the head back slightly if you need to, and ensure that hand under the cheek is maintaining that open position.
There are 2 critical caveats here, based on our experience on the road. First, you must turn the casualty onto the opposite side every 30 minutes.
Why is that?
It's to prevent pressure damage, particularly if you've got a prolonged wait for the ambulance.
And then the second one.
Second, If you have a pregnant casualty in the later stages of pregnancy, she must be placed onto her left-hand side. No exceptions.
And the reason for that is purely mechanical, isn't it?
It is. This positioning prevents the fetus from compressing the inferior vena cava, a major vein, which can restrict the return of blood to the heart and compromise both the mother and the baby.
That thoroughly covers the foundation of BLS. We've established the rhythm, the sequence. Now let's move into specific emergencies involving breathing, starting with choking.
A really common and very frightening scenario in a school canteen or a playground.
The immediate distinction you have to make is between a mild and a severe obstruction. Your action is entirely dictated by this difference.
With mild choking, the airway is only partially blocked. The casualty is still able to cough, speak, or cry, although they're clearly in distress.
They might be clutching their throat, but they are definitely moving air.
They are. So the treatment here is simple and vital. Encourage them to keep coughing. The natural cough mechanism is usually far more effective than anything we can do manually.
But if they transition to severe choking, that's a different game.
Completely different. The airway is now completely or almost completely blocked. They will be unable to cough, speak, or breathe. You might see them grasping at their throat, and their skin color, especially around the lips, may quickly turn blue or gray. That's cyanosis, due to lack of oxygen.
They are in acute distress, and they need rapid physical intervention.
The standard UK treatment for a choking adult or child is a cycle of up to 5 back blows, followed by up to 5 abdominal thrusts.
Let's talk through that.
You need to stand slightly to the side and behind the casualty, support their chest with one hand, and lean them well forward. Then administer 5 sharp, deliberate back blows between the shoulder blades using the heel of your other hand.
And if the obstruction isn't cleared after those 5 blows,
you move immediately to abdominal thrusts.
Yeah.
Stand directly behind them. Place your arms around the upper part of their abdomen, making sure you lean them forward to let gravity help.
Right.
Clench one fist, place it between the navel and the rib cage, that soft spot. Grasp that fist with your other hand and pull sharply inwards and upwards. It's a distinct J-shaped motion, and you repeat that up to 5 times.
Now, if you're dealing with an infant, a child under the age of 1, the protocol is slightly different, isn't it? Their internal organs are much more fragile.
They are. So abdominal thrusts are replaced by chest thrusts. You position the infant face up along your forearm, supporting their head, and use the tips of 2 fingers to deliver up to 5 thrusts to the center of the chest.
But the back blow technique is similar.
It is, yeah. Delivered while supporting the infant's head face down along your forearm.
And you continue this alternating cycle of 5 back blows and 5 thrusts until the object is expelled, the casualty starts breathing normally, or...
And this is the critical red flag.
The casualty becomes unresponsive?
At which point the choking protocol stops dead and you commence CPR. Because the obstruction is still in the airway, the A and B steps of your CPR now also become part of the mechanism to try and dislodge that object.
And one final important point on choking. Anyone who has received abdominal thrusts must seek medical attention.
Always. There's a small but significant risk of internal injury, particularly to the abdomen. They need to get checked out.
Okay, let's move from a mechanical blockage to medical breathing emergencies, starting with asthma attacks. These are incredibly common in schools, and staff need to be highly confident in assisting a student or a colleague with their medication.
Recognition starts with signs of difficulty breathing, often accompanied by wheezing, that tight, high-pitched noise. In a severe attack, you really need to pay attention to their speech.
What are you looking for?
They may struggle severely, being unable to complete a full sentence without gasping for breath. You might also notice them using their accessory muscles, the muscles in their neck and shoulders, to pull air in.
And their lips might develop that blue or gray tinge, the cyanosis?
Exactly. The immediate treatment has one critical positioning rule. Always sit them upright. Never, ever let an asthmatic casualty lie down.
Why is that so important?
Sitting upright just allows them to use their lungs most effectively. You must then assist them immediately with their own prescribed reliever inhaler, which is usually blue.
And we must strongly stress the use of a spacer device if it's available.
Oh, massively. Your source material confirms it, and we see it on the road all the time. Inhalers are vastly more effective when used with a spacer.
How does it work?
The spacer holds the medication mist, ensuring the casualty gets a much higher dose deep into their lungs, rather than having it just deposit on the back of their throat. They should take 1 puff, breathe 4 times from the spacer, and then repeat.
And when do we call 999? What are the red flags?
If there is no improvement after assisting them with 10 puffs of their inhaler, If they become exhausted from the sheer effort of breathing, or if they lose the ability to speak clearly, immediate emergency help is required in those cases.
Finally, under breathing emergencies, we have hypoxia, which is just oxygen starvation. This is the body's response to not getting enough oxygen, which can stem from severe asthma, choking, or even certain illnesses.
The recognition signs are often neurological, so confusion, agitation, rapidly turning blue, fast, shallow breathing, hyperventilating, sweating, and just a general profound weakness.
And the treatment focuses on maintaining the status quo while you're waiting for help.
Pretty much. You maintain a clear airway, you call 999 immediately. Hypoxia is a critical emergency. You calm and reassure the casualty, monitor their vital signs continuously, and importantly, you have to be prepared to carry out basic life support the moment they deteriorate or stop breathing.
That transitions us neatly into the next major life threat.
Yeah.
Massive blood loss.
Yeah, we're discussing life-threatening bleeding, tourniquets, and shock. Now, this area has seen the most dramatic evolution in civilian first aid protocols, and it's where we'll really need to dive deep into the why behind the changing rules.
So, starting with the basics, identifying the source of the bleed. We classify it into 3 types. Arterial bleeding is bright red, oxygenated blood that spurts rhythmically in time with the heartbeat. This is the most immediately life-threatening due to the pressure behind it.
Then you've got venous bleeding, which is dark red, deoxygenated blood that flows or gushes continuously from the wound. Now, while it doesn't spurt, the sheer volume of blood in the veins means it is also immediately life-threatening and can lead to very rapid exsanguination.
Bleeding out.
Bleeding out, yeah. The third is capillary bleeding, which is that slow oozing from the skin surface, typically from grazes or minor cuts. It's generally not a life-threatening concern unless, infection sets in later.
And we also briefly classify the wounds themselves, just so we have the terminology.
Right. So a neat cut is an incision, a jagged tear is a laceration, a graze is an abrasion, a bruise is a contusion, a piercing injury is a puncture, and a penetrating wound is where an object is embedded.
And we define major bleeding by what we see.
Exactly. Blood spurting or flowing rapidly, blood pooling quickly on the floor or around the casualty, or bleeding that simply cannot be controlled by your initial standard first aid application of direct manual pressure. This is what demands an escalating intervention.
So, for general treatment of severe external bleeding, the protocol starts with the gold standard, which is direct pressure.
Yep. You apply pressure directly onto the bleeding site using a sterile dressing or a clean pad. And you need to get pressure into the wound, not just resting on top of it.
And if blood seeps through that first dressing, you do not remove it.
No. You apply a second dressing directly over the top to reinforce the pressure. Removing that first dressing prematurely just disrupts any clotting process that might have started.
However, and this is a key distinction, if blood soaks through the second dressing, you must remove both dressings and start again with fresh ones.
And why is that?
It's because the saturated dressings have become ineffective and bulky. Removing them allows you to find the exact point of bleeding again and apply really focused pressure to create a superior seal. You're resetting.
Good point. Now, if the casualty has an embedded object, a penetrating wound, you must never remove it.
It could be acting as a life-saving plug.
Precisely. So you apply pressure on either side of the object, dress carefully around it, support the injured part to prevent any movement, and call 999 immediately.
And throughout all of this, for any severe bleeding, we are simultaneously treating for, or at least preventing, shock.
Always. You need to lay the casualty flat, raise their legs unless they're injured, to increase blood flow back to the core organs, keep them warm with a blanket or a jumper, and support the injured part.
Yeah.
And crucially, you must monitor their circulation every 10 minutes.
How do you do that?
By checking the color return, the capillary refill in, a nail bed beyond the bandage.
Okay, now let's tackle the advanced protocols that are now being integrated into FAW courses, tourniquets and wound packing.
This is a big change. The UK Health and Safety Executive, the HSE, specifically recommends that FAW training should now cover the application of an improvised tourniquet sew using a triangular bandage tightened with a twisting device and improvised wound packing using bandages or clothing.
And they also acknowledge that manufactured devices like commercial CCAT tourniquets or hemostatic dressings are appropriate where a workplace risk assessment identifies a specific high risk of catastrophic bleeding.
Say in a DT workshop or a maintenance area with heavy machinery.
Exactly. And this is where we need the deep dive. Why are these protocols so specific? It all comes down to performance, doesn't it?
It does. The vast majority of commercial tourniquets, like the popular CAT, are inelastic. They rely on a mechanical windlass, a twisting stick, to generate pressure.
And what the data tells us, especially from trauma centers, is quite fascinating. It's actually common for patients who had an inelastic tourniquet applied to arrive at A&E with a palpable pulse distally.
Meaning the arterial occlusion had been lost.
The tourniquet had failed.
Essentially, yes. One study, reviewing applications by highly trained personnel, found that arterial occlusion had failed in a significant number of cases, resulting in what was basically a venous-only occlusion.
Wait, venous-only occlusion sounds, well, it sounds harmful. If trained people are failing that often, why is it such a problem? For a teacher using an improvised device, what's the simple insight here?
That's a brilliant point, and we do need to simplify the physics. Think of the limb like a bottle of water. When an inelastic, rigid tourniquet is applied very tightly, it generates high external pressure. But the fluids inside the tissue, the blood, the interstitial fluid, they act under hydrostatic laws.
They move away from the pressure.
They immediately shift away from that high pressure point towards areas of lower pressure.
So as soon as you stop twisting the windlass, that pressure underneath the tourniquet starts dropping because the fluid is literally migrating away from it.
Precisely. And that pressure drop means the device quickly loses the high pressure needed to fully stop the thick elastic arterial wall. However, the thinner, softer venous walls, they remain completely compressed. And that is the failure point.
And this is why it causes harm, isn't it? If the arterial blood can still pump into the limb, but the veins are squashed shut, the blood can't flow out.
It's like turning on the tap but blocking the drain.
Right.
And this painful backflow causes rapid venous engorgement, which dramatically increases the rate of blood loss from the wound, and it causes a profound, excruciating pain, often referred to as venous tourniquet pain.
Whereas elastic devices, like the SWAT, often maintain pressure better over time.
They do, because they accommodate that fluid shift through their built-in recoil and tension.
So what's the practical takeaway for someone using a triangular bandage as an improvised tourniquet?
It comes down to width, doesn't it? You mentioned the LOP equation earlier, which sounds incredibly complex.
Yeah, it is, yeah.
But the core mechanism is about pressure distribution. That's the key takeaway. Width matters. While the full limb occlusion pressure equation is academic, the result is practical. Wider tourniquets require significantly less pressure to stop arterial flow than narrow ones.
So a wide elastic wrap or a widely folded triangular bandage is kinder, less painful, and less likely to cause tissue damage than a narrow strap or a rope twisted hard.
Exactly. You want to distribute that pressure as much as possible.
And this philosophical shift informs why some specialized devices are designed not just to cut off arterial supply, but to apply massive, targeted, direct pressure over the wound first.
Yeah. The rationale, especially in civilian first aid, is that this approach reduces the risk of causing damage in untrained hands compared to just aggressively applying a narrow arterial occluder high up the limb.
Right. We'll wrap up this section by covering hypovolemic shock, the inevitable consequence if severe bleeding or fluid loss from burns or severe vomiting is left unchecked.
It's a life-threatening condition caused by losing 20% or more of the body's fluid volume.
And the recognition signs are classic. The casualty will be pale, potentially blue or gray, cold and clammy sweaty. They will have fast, shallow breathing and a rapid, weak pulse that might be difficult to find.
And their mental status can decline quickly, leading to dizziness or confusion.
Treatment is simple, and it adheres to the shock prevention steps we already discussed.
Yep. Treat the cause, so stop the bleeding. Lay the casualty flat, raise their legs above heart level unless they're injured, loosen any tight clothing, and keep them warm with a blanket. Call 999 immediately.
And crucially, do not allow them any food or drink.
No. That could complicate later medical procedures.
We've moved through BLS and managing massive hemorrhage. Now we can transition smoothly into major illness and medical emergencies, which are perhaps more frequently encountered in a standard school day than severe trauma.
I'd say so. We'll start with the diabetic emergency, focusing on hypoglycemia or hypodangerously low blood sugar. This is the most common emergency you'll see from type 1 diabetic students.
And the onset of a hypo is very fast. The signs include shaking, profuse sweating, a wobbly feeling, paleness, and intense hunger.
And often, they exhibit really dramatic personality changes. They might become irritable, aggressive, or tearful, and severely confused.
The treatment is to get 15 to 20 grams of fast-acting glucose into them immediately. We're talking quick sugars.
So 5 to 7 jelly babies, glucose tablets, or a small glass of non-diet sugary fizzy drink. Then you wait 10 to 15 minutes, allowing that sugar to take effect.
If they are recovering and feel better, the next step is absolutely critical. You follow up with a slow-release carbohydrate.
A biscuit, a piece of fruit, or a sandwich. This just prevents their sugar level from crashing again once that fast-acting glucose is burned off.
And the red flag here.
Call 999 if the casualty becomes unconscious or if they're unable to swallow safely. You must never attempt to give an unconscious person food or drink. It risks choking and aspiration, compromising their airway.
Next up, seizures, commonly associated with epilepsy. We're primarily concerned with the tonic-clonic seizure, which affects the whole body.
Some casualties might experience an aura beforehand, a strange smell, taste, or sensation.
The seizure itself involves two phases. The tonic phase is muscle rigidity, arching the back, and potential cyanosis.
And this is followed by the clonic phase, which is that violent, rhythmic jerking, teeth clenching, and possible loss of bladder or bowel control.
First aid for a seizure has mandatory rules. Rule number 1, time the seizure. From start to finish, this information is vital for the ambulance crew.
Rule 2, protect the head. Place something soft, like a folded jumper or a coat, underneath it. Rule 3, clear the area by moving furniture or anything dangerous away from them.
And there are two things you must absolutely not do.
Never restrain the casualty's movements and never place anything in their mouth, even if they bite their tongue.
People often panic and think they need to prevent the tongue from being bitten, don't they?
They do, but interfering risks injury to them or to you, and it risks compromising the airway.
Once the violent movements stop and they are unconscious but hopefully breathing, you immediately put them in the recovery position and just reassure them as they come round.
And when is it a 999 event?
If the seizure lasts more than 5 minutes, if it's the casualty's first ever seizure, or if one seizure follows another without them regaining consciousness.
That's status epilepticus, and it's a critical emergency.
It is. Now, we move to anaphylaxis, the extreme, life-threatening allergic reaction. Speed here can literally be the difference between life and death.
Recognition requires us to use the ABC approach to identify the immediate threats. Airway symptoms include swelling of the tongue, throat tightness, or difficulty speaking.
Breathing symptoms are noisy breathing, wheezing, and a feeling of a tight chest.
And circulation symptoms include dizziness, feeling faint, pale, clammy skin, and a rapid, weak pulse. A rash or hives might be present, but you cannot wait for skin symptoms to appear.
The treatment is decisive. Administer the adrenaline autoinjector, the AAI, immediately. Do not wait for symptoms to worsen.
Injectors like EpiPen or Jext go into the outer mid-thigh. As soon as that adrenaline is delivered, you or a delegated colleague must call 999 and state anaphylaxis clearly so the dispatcher knows the severity.
Positioning is nuanced and important. If they're feeling faint or going into shock, you lie them flat with their legs raised to assist blood flow to the core.
Unless they're severely breathless, in which case you must sit them up slightly. If they become unconscious, they go straight into the recovery position.
Let's detail the Jext application procedure, as this is something school staff handle frequently.
Okay, you grasp the device in your dominant hand, pull off the yellow safety cap, place the black tip at a 90-degree angle firmly against the outer mid-thigh.
Push until you hear a click.
Hold it in place for a slow 10 seconds, then remove it and check the viewing window for the colored rod to confirm the dose was delivered. Then you massage the area afterwards.
And crucially, they may need a second dose.
They may. If symptoms are not improving or are worsening 5 to 15 minutes after the first dose, the second AAI should be administered.
Finally, cardiac emergencies. We'll look first at a heart attack caused by a blockage in the coronary arteries supplying the heart muscle.
Recognition involves a sudden onset of crushing chest pain that may spread to the jaw, neck, arms, often the left one or the back. This is usually accompanied by profound shortness of breath, nausea, and cold sweats.
Treatment is immediate. Call 999, sit the casualty comfortably, usually semi-reclined with their legs drawn up, as this is often the least painful position. Loosen any restrictive clothing.
And here's the paramedic insight. If available, and the casualty is conscious, assist them to self-administer 150-300 milligrams of chewable aspirin. Aspirin is an antiplatelet drug that helps stop the clot from growing larger.
And we differentiate this from angina, which is a similar tightening or squeezing chest pain, but it's caused by narrowed, not blocked, coronary arteries.
The key difference is that angina is typically relieved by rest or medication, like a GTN spray, and it lasts only 1 to 15 minutes. If it's their first time experiencing this, or if the pain lasts longer than 15 minutes, you must always treat it as a heart attack and seek emergency help.
And lastly, stroke. Time lost is brain lost. We rely heavily on the FAST acronym for recognition.
Facial weakness. Can they smile? Has one side of the face dropped? Arm weakness. Can they raise both arms equally and keep them there?
Speech problems. Is their speech slurred, confused, or difficult to understand? NT.
Time to call 999 immediately.
Treatment hinges entirely on the speed of their 999 call. If the casualty is responsive, you position them comfortably, usually lying down with their head and shoulders slightly raised.
And if they are unconscious, place them in the recovery position, ideally with the affected or paralyzed side downwards, all while monitoring the airway and preparing for BLS.
Right. We've established the life-saving medical responses. Now we should dedicate some substantial time to trauma, dealing with bones, head, and spinal injuries. These are high-probability events in busy school playgrounds, sports halls, or staircases.
They really are. So, starting with fractures, a break in the bone and dislocations, which is when bones forming a joint become misaligned.
The general signs are pain, swelling, and bruising, often coupled with a visible deformity and inability or reluctance to move the limb.
And sometimes a noticeable, audible grating sound or sensation, which we call crepitus, as the bone ends rub together.
The treatment must focus on keeping the casualty absolutely still and immobilizing the limb. This is paramount.
Do not attempt to realign the bone, even if it looks badly displaced. You immobilize the limb in the position it was found, the position most comfortable for the casualty, using bandages, splints, or cushions for support.
And if you encounter an open fracture where the bone has broken the skin,
you must cover the wound with a sterile dressing. And crucially, you apply direct pressure around the bone to control bleeding, but never directly onto the exposed bone itself.
For younger students, we must be aware of green stick fractures.
Ah, yes. Because a child's bones are more pliable, they may bend and crack rather than fully snapping through. The signs can be really subtle and confusing, sometimes easily mistaken for a simple sprain.
So if a child is reluctant to bear weight or move a limb after a fall, always treat it seriously.
Always. And speaking of soft tissue injuries, sprains, which is ligament damage, and strains, muscle or tendon damage, the traditional first aid treatment was RICE.
But we should give you the modern evolution, the high-value insight, which is POLICE.
It's a great acronym.
It is. POLICE stands for protection, so protect the injury from further harm. Optimal loading.
Which is the big change.
It is. Gradual, pain-free exercise is often better than complete rest for promoting healing. Then ice, apply cold over a barrier, compression, so a support bandage, and elevation, raising the limb above heart level. The shift to optimal loading recognizes that movement, where possible, actually aids recovery.
Yeah, but the RICE or police protocol is great for minor soft tissue injuries. We must remember the red flags, though.
Any suspected femur thigh bone or pelvis injury, or if the casualty shows signs of shock, requires an immediate 999 call.
These areas hold vast amounts of blood, and the internal bleeding risk is extremely high.
Moving up to the head injuries are never to be dismissed, even if the initial symptoms seem mild. We classify them as concussion, cerebral compression. That's a highly dangerous buildup of pressure inside the skull and skull fracture.
And while a bump might just cause a headache, you must watch for the severe dangerous signs. Any loss of consciousness, even briefly, persistent vomiting, so more than once, seizures, unequal pupil sizes, unusual drowsiness.
Or clear fluid or blood coming from the ears or nose.
And that clear fluid, by the way, is cerebrospinal fluid, or CSF. Its leakage signifies a potential break in the skull base. It's a massive red flag.
General treatment is to keep the casualty still, raise their head and shoulders slightly, and apply a cold compress to the injured area. You gently control any external bleeding, being careful around the eyes or ears.
But the most important rule in a school setting is the observation rule. You must monitor the casualty's alertness and condition for a minimum of 48 hours and seek urgent medical help if any of those serious signs develop.
And never leave someone who has suffered a head injury alone overnight.
Never. Finally, we address the most feared injury: spinal injuries. Damage to the spinal cord can result in permanent paralysis or death, so the first aider's primary goal is to prevent any movement of the head or neck.
The signs include severe pain or tenderness in the neck or back, an unusual, often twisted position of the head or body, tingling or numbness in the hands or feet, or loss of bowel or bladder control.
The critical treatment is Mills manual inline stabilization. This means firmly holding the casualty's head in a neutral position, keeping it directly in line with their spine. You must not move the conscious casualty unless they are in immediate danger of fire or perhaps the edge of a busy road.
You just keep them still, immobilized, and warm.
But if the casualty is unconscious, the priority shifts slightly, although the principle of Mills remains. If they are not breathing, BLS takes priority over everything.
And if they're breathing?
Do not move them unless the airway is clearly compromised. For example, if they start vomiting or choking on blood, airway clearance always takes precedence.
And if you must move an unconscious casualty to clear their airway or place them in the recovery position,
You use the standard technique, but you strive to maintain that head and neck alignment as best you can. If you have 2 or more rescuers present, the log roll technique should be used, ensuring one person maintains Mills throughout the entire turn to keep the spine straight.
we've covered major life threats and trauma. Let's conclude our deep dive with a focus on 2 specific incident types you might encounter: burns and scalds, and poisons.
Okay, so burns and scalds are classified by severity. Superficial burns, or first degree, involve only the epidermis, causing redness and pain. Partial thickness burns, second degree, go deeper, causing raw skin, intense pain, and blisters. They carry a high risk of infection.
And full thickness burns, or third degree, damage all layers, often looking dry, leathery, or charred. And here's the paradoxical element: they may be less painful.
Because the nerve endings have been destroyed, these carry the highest risk of shock and infection.
Treatment is immediate and simple. Remove the casualty from the heat source and remove any restrictive clothing or jewelry if they are not stuck to the skin. Then, the absolute critical step is cooling.
Cool the area with cool running water for a minimum of 20 minutes. 20 minutes is a benchmark for reducing tissue damage and pain. It feels like a long time, but it's essential.
After cooling, you must cover the burn. You use a loose, sterile dressing or, and this is highly effective and widely available in schools, cling film.
Plastic wrap. It's ideal because once you discard the first few inches to ensure it's sterile, it's transparent so medics can see the wound. It's protective, it doesn't stick to the skin, and it helps retain moisture and cool temperature.
And you can even continue cooling with the cling film applied.
You can. Red flags for a 999 call include any burn covering more than 5% of the body. And remember, the casualty's hand is roughly 1% of their total body area, or any electrical burns, chemical burns, or burns affecting the airway, eyes, or face.
And for anything over 9% partial thickness, you should also be preparing to treat the casualty for shock.
Absolutely. Finally, poisons. A poison is any substance that enters the body via ingestion, inhalation, absorption, or injection, which interferes with normal body function.
So this could be anything from chemical cleaning products to inhaled fumes from a science experiment.
Exactly. General recognition signs are broad. Stomach pains, nausea, changes in heart rate, impaired vision, confusion, or the distinct smell of fumes.
General treatment starts with ensuring scene safety. Remove the cause, so ventilate the room, or remove the casualty from the cause. Call 999 immediately.
And if possible, provide the source of the poison, the container, or the packaging to the medical team when they arrive.
The key rule for ingested poisons is do not encourage vomiting or excessive moving around.
This can just accelerate the absorption of the poison. If the substance is corrosive, like certain cleaning chemicals, rinse the mouth thoroughly and give frequent small sips of water or milk, but only if the casualty is fully conscious and can swallow safely. Always protect that airway and be prepared for BLS.
Right. We have thoroughly covered this manual, from the fundamental sequence of DRABCD and the chain of survival, right through to complex trauma management, medical emergencies, and specific injuries.
We've given you the signs, the symptoms, and the treatments for managing emergencies involving both students and adult colleagues.
And as a final takeaway, something for you to integrate into your practical training with Paul, let's circle back to that crucial discussion we had on severe bleeding and the mechanics of a tourniquet.
Yeah, we spent some time talking about the physics of that pressure loss, didn't we?
We did. We noted that the safe limit of a tourniquet is often stated as 2 hours, but the pressure beneath that device can drop very quickly due to fluid shifting away from the compressed area.
And if the arterial flow returns, but the venous return remains cut off, that situation is actively worsening the casualty's condition.
Exactly, and we emphasize that the most common sign of this failure, when arterial occlusion is lost, leading to that dangerous venous engorgement, is a sudden acute spike in pain, that agonizing venous tourniquet pain.
So when you apply that improvised or commercial tourniquet, and your casualty, whether it's a student or a colleague, cries out in pain during transport, it's far too easy to dismiss it with the thought, well, tourniquets hurt.
But that pain isn't just an unfortunate side effect of stopping the blood. It could be a crucial red flag.
It could be indicating venous occlusion and escalating harm, meaning you are unintentionally speeding up their blood loss and their suffering. The right answer isn't always pain relief. The right answer is critical thinking and reassessment.
So here's our provocative thought for the listener. If you have applied a tourniquet in the field and the pain suddenly becomes excruciating, or if the distal pulse returns, you must immediately recheck for bleeding control effectiveness. You might need to tighten or reapply a wider device slightly higher up the limb.
Always check the pulse distal to the tourniquet. That continuous critical monitoring is what separates good first aid from truly great first aid.
That's everything we wanted to cover to support your theoretical understanding. We hope this deep dive helps solidify the protocols and insights you need.
Thank you for joining us, and we wish you the very best of luck with the remaining practical sessions with Paul Kenny in the First Aid Garage.
Cheer you.